confusing.
Dee, I want to thank you for running for the legislature. 3 women, I think that's wonderful. You sacrifice a lot of your family and everything to be up there, and we appreciate you. Now, my question is, how about the doctors? They're refusing to take, the primary doctors are refusing to accept Medicare patients.
So there's been, what Dee said is true, there have been issues with getting primary care providers to accept Medicare, and part of that is that we don't have enough primary care providers. Remember how I said the more you do, the more you get paid? What we ended up doing was making it that the least well-paid doctor was a primary care provider. And then, so a lot of the doctors go into becoming a specialist because they can make a lot more money. And so they're going to be reforming through Medicare how doctors are paid and making it so that primary care doctors are starting to get paid more and specialists will be paid less. And that will help open it up for senior patients to have more primary care doctors who they can see. And in fact, Medicaid pays the worst of all for primary care. And so I actually started, I think this year or last, I don't remember if it's now or next year, but Medicaid has to pay primary care doctors at least as much as Medicare right now. Again, trying to work on that whole issue of getting more people to do primary care. And even though I'm a primary care doctor, I can tell you that most people actually would be okay with a primary care nurse practitioner or physician's assistants because they're really good at managing people with chronic stable disease. The one thing that I think a nurse practitioner can do that a doctor can do is if we don't know what's wrong with you. If you come in and you're sick and no one knows what's wrong, I would rather at that point be seeing a doctor. But for example, if you have diabetes or high blood pressure, don't tell the doctors this, but there's actually research that shows that the nurse practitioner keeps you in better control than a doctor does. And it's because like they're used to having to follow the rules. And doctors are like, you can't make me do that. so for stable patients, so I think we'll see a lot more of that too, more nurse practitioners and PAs serving as primary care providers, and doctors being more consultative and taking care of people when they have unusual diseases.
May I add to that as a doctor's wife? If insurance controls what doctors are paid, and they get paid for everything they took.
Yes.
And if you're a Medicaid patient and you are not obliged to pay for anything very often, you just don't appear. So doctors assume a lot of responsibility for people that we don't realize.
Yes, this whole payment system has just become a horrible game in which a lot of doctors are ending up losing. So what you implied is correct. What I say is that if you're uninsured, we have this thing called the Co-Auto Indigent Care Program that will pay some providers some, but for every dollar they bill you, they get 30 cents. If you have Medicaid, for every dollar they bill you, they get 60 cents. If you have Medicare, for every dollar they bill you, they get 70 cents. And if you have private insurance, you get anywhere from 90 cents to $1.40. So that's why when doctors only have so many slots, who are they going to choose to fill it, right? The person who can give them $1.40 a visit instead of the person who can give them 50 cents a visit. And so what's happening now, which I think is a good change, is that more and more doctors are becoming salaried. So they don't have to worry about what the payer mix is of people that they see. And in fact, of doctors coming out of training, so this is the new generation of doctors, over half of them are taking salaried positions. So I think that will help control this so that we don't see as much price discrimination for patients, because eventually, if we're lucky, we'll all be over 65 and on Medicare. The opposite choice is not a very good one.
Okay, what I've been hearing is that they are planning to cut on Medicare. They're planning to cut the reimbursement to the doctor by 30%. I mean, what choice does that doctor have if his income keeps being lowered? He doesn't. The worst thing for his business is going to be a lot of Medicare patients.
Right, and actually, there's this rule where Congress has to set the rates for what gets paid to Medicare, and there's this complex thing that I don't really understand, to be honest, and I understand a lot about healthcare. called the Sustainable Growth Rate. And every year, Congress has not made a decision about what's going to happen with that. And so the American Medical Association, or AMA, is very focused on that, because every year, basically, they're at risk for Congress saying, this year, we're going to cut your rates. And I can tell you so far, every year, Congress says, no, we're not going to do that. And so they're trying to come up with a more sustainable way of funding Medicare, so every year a doctor doesn't get this panic that they're going to be cut 30%. I would be really surprised if Congress could ever get that through, because not only are doctors opposed to that, but all our senior patients, who, as you know, are some of our best voters in the country, are really being a strong voice on this and saying, look, it's not fair to penalize doctors for taking care of the sickest people in our system. And so they're, one of the things in the Affordable Care Act is to relook at how Medicare is paid and reimbursed, because this is recognized as a problem. And as long as the doctors keep doing their good advocacy, and as long as our representatives would like to stay in their jobs in Congress, 30% fall is not going to happen.
But you were talking 2 minutes ago, or one of you were talking 2 minutes ago about a 3-tier plan.
Oh, so what the 3-tier plan
It sounds
is,
like
Yeah.
those who have money are going to get good care, and those who don't are not going to get good care.
no, if the 3 tiers is sort of the kind of insurance you can buy. And so you could buy an insurance that, where you pay 40% of your cost and the insurance pays 60%, and that's the lowest tier, that's bronze. Or you could buy a plan where you only have to pay 30% out of pocket and your insurance pays 70%, and that's silver. And then there's a plan where your insurance pays 80% of the cost and you pay 20%, and that's gold. And another one where your insurance pays 90% of the cost and you pay 10%, and that's platinum. The amount the doctor gets paid for all of those is the same. What differs is how much you pay versus how much the insurance pays. And so when you pick your plan, you'll decide, how would I rather pay for my health care? Pay more for my insurance so that every time I visit I don't pay so much, or pay less for my insurance but every time I visit I pay more. So that's what the tiers are. It's you deciding how much you want to pay up front in insurance versus every time you visit on co-payments and things.
Well, if you're living on Social Security, I doubt that you're going to pay for the highest.
Right. So this is for people who have purchased private insurance. This is not for Medicare. Medicare stays the same.
Oh, okay.
Is there still a maximum out of pocket on all those plans? Because
Yes.
the problem with the 60/40 is, what if it's $1 million? Is there a maximum though out of pocket?
There is
on
a
those
maximum
plans?
amount of pocket tied to your income.
Okay.
And do those tiers all have the same level of service, or do the tiers change in terms of what services you can access?
And that will be up to the insurer and how they design it. So there's going to be a baseline level of services that Representative McCann referred to, the essential health benefits, that everybody will have to offer. And then people can choose to offer more and charge more for their insurance product if they like. The basic right now is still being determined in Colorado, and if you go to that getcoveredco.org, it has a link to the Division of Insurance and where those plans are. But the one that they're, like if we don't pick one by a certain date coming up, we'll automatically have the one that's most popular in the small employer market, which is a Kaiser plan. So at the very least, our basic will be like a Kaiser plan.
And these are state-based, so each state will vary.
Yes.
In essence, the insurance companies control everything.
Yes.
You had talked about, and I just want to make sure I'm clear on timing, for pre-existing conditions, moving from one employer to the next, that as of January, that will...
2014.
Okay, yeah, not January 2014, so it's not...
Right, so with the exchange in October of 2013, when you can start picking your products, that will be based on no discrimination.
But pre-existing conditions has already kicked in for kids.
Right.
So they cannot discriminate against kids with pre-existing.
At what age, what's the age group?
Under 18.
18, I think.
Pass a lot of, we're all 17, so...
I have a couple of questions. On the employer-provided insurance side of the exchange, will it be mandated that coverage be available for organizations with one employee? Because right now that's extraordinarily difficult to find. employer provided insurance for a single employee. They want, because of the economy of scale, of course, they want, larger groups, 5, 10, or 25 people. I don't really think the answer to that.
Yeah, in the federal plan, in federal law, there is not a business group of one, which Colorado has had.
Right, right.
And, I'm not sure about that decision yet. Right now, they're looking at the small group market as 50 or under. And it's my understanding that business groups of one would be able to choose whether they shop in the shop exchange or in the individual exchange.
Senator, to follow up on that, one of the approaches to that was that professional trade associations, National Association of Realtors, by example, could aggregate all their single employer members and go purchase as a large company would. That was disallowed at the federal level before, and that's been protected over the years. Did that change with this, or is there going to be an option for those groups to?
I don't think that changed.
So these are real technical questions. For those of you who don't know, when you buy insurance right now, if you're an individual, you're in one group of people who purchase insurance, and many times that's the most expensive way to buy it. If you're part of a small business, meaning 50 people or less, then you're in a different group of people when you buy it, and that's a little bit cheaper than individual. And if you're part of a big business, you get the cheapest insurance of all. And this has to do with they collect all the money in 1, 2, or 3 pools, and they pay all the bills out of that. So the more people they have in that pool, the less they can charge each person. Which is why another day I'll tell you about my idea for how we redo the whole thing for Colorado. So we all get the cheap price. But so what this gentleman is asking is, in the health insurance exchange, people will either be part of the individual market if they don't belong to any company, or the small group market if they're part of a small business. And I forgot to mention that small businesses will also be eligible for tax credits and subsidies to help them help their employees buy insurance under the Affordable Care Act.
And actually, that's in place now for the second year.
Oh, great, thank you.
Well, I think, can't small businesses opt out and just pay a fine?
Yes, and thank you.
And I'm wondering if small businesses opt out and just pay the fine, where does that leave their employees? Then they
Their employee can go in
purchase
as an individual to the
as an
exchange.
individual.
Yes.
And
So,
they too could opt out and pay a fine, but,
yeah.
and that's the thing that bothers me. I'm glad you brought that up, because that's the thing that bothers me the most is, I don't think the fine is high enough. And I think that's gonna have to go up, so that you bear a bigger burden if you make that decision to not participate.
So, probably one of there are 2 main reasons why this Affordable Care Act was rejected and sent to the Supreme Court. One was because of something called the individual mandate. And what the individual mandate means is that starting in 2014, either you have to have insurance or you're going to have to pay a tax penalty. And so there were states that said, Colorado Attorney General Summers was one of them, that said Congress doesn't have the authority to force us to purchase private insurance. And what the Supreme Court said was, well, you're right, they can't force you to buy a private product, but they can force you to pay a tax. And so what this is really a tax. If you don't have insurance, you have to pay an extra tax. And so that starts in 2014, so that anyone who doesn't have insurance will be assessed a tax penalty, and it'll be collected through the IRS. But what Senator Boyd said is true. It's actually not a very high tax. And I don't remember that number off the top of my head, I'm sorry to say, but
$95.14, and in 17, it goes up to $695.
so the most you would be penalized is $700 a year for not having purchased insurance, which, as we said, might cost you $10,000 to $12,000 a year. But of course, you'll be getting subsidies from your employer and from the federal government to purchase that as well. It's estimated in Colorado that about 100,000 people or less would choose to pay the penalty rather than buy insurance. And this, I'm not sure how they make these kinds of estimates. but otherwise people will take advantage of it if they can.
And then by paying that penalty tax, they would just go to the emergency rooms.
Right. They all continue to pay for their care because
By
they
the
would go to the
way,
emergency.
I have United Health, and I'm never sick enough to get above my $2,000, which is great. I'm almost there this time with cancer things, but are they getting any money back? United Health, is there some?
I don't know, and,
They
you know,
use
if you
their-
contact, I'll give it to you, the Colorado Consumer Health Initiative, I bet they can find out for you.
Yeah, because they're so big.
Yeah.
I'm interested in this navigator thing. How many navigators will there be and who pays for those?
I don't know how many navigators there will be. That's part of the decision that, and what their training requirements would be, and their, not only training, but also, knowledge and what requirements there will be for navigators. The board, that's a decision that will be made in the course of the next year by the board of the exchange.
How many people are they expected to serve?
Is it expected to use the exchange?
How many people will need the services of a navigator?
Yeah.
That, probably quite a few, especially in the individual exchange. And, interestingly, the minute the ink was drying on the bill, brokers started to call themselves broker navigators. I think there is definitely a role for brokers, and that is part of the discussion that the board is having. But navigators can be people in the community. They can be people with, say, the Colorado Consumer Health Initiative that Senator Aguilar just mentioned. People who are advocates can be people who would help people navigate the system. But if they will require certification and what that certification will be, we don't know yet. That's in the things yet to be determined.
And that would be
One of the-
paid by Colorado tax money or
Paid by the exchange.
paid by, Colorado tax money?
Well, whoever is purchasing an exchange. Actually, Colorado is not allowed to put any money into our exchange as a state. It will all be paid through premiums. So part of what they have to calculate in their costs and premiums is what it costs them to run the exchange. And there is a subcommittee of the exchange on outreach and education. Again, if you go to that getcoveredcolorado.org, you can find out when they're meeting, and that will be your best way to get sort of up to the minute information on what's happening with the whole navigator decision. I know there's a lot of lobbying going on by brokers to have it be brokers, but I know that people who are private healthcare reform recognize that that's part of, unfortunately, the waste in our healthcare system, because that ends up becoming a cut of the money. And if you keep having people cut the money before you get to paying for your medical costs, things cost more. Yes, ma'am.
How confident are you all that this will eventually break down the cost of healthcare?
So, that's a trick question, let me tell you why. Because one of the things that nobody is spending much time talking about, and we have somebody here from the Alliance for Retired Americans, is that as a population, we're aging. And as we age, our medical costs go up, and more of us need something called long-term care, which is even sometimes living in a nursing home, but at its best is somebody coming into your home 1 or 2 days a week to help you do things like get groceries, get your laundry done, take a bath if you're not safe to do that alone. And so I think if we were to look at traditional costs as they were fixed today, that yes, those will go down, but total medical costs continue to expand because of our aging population and long-term care, and frankly because of medical advances. There are things every year that are new in medicine that we weren't doing a year or two ago that end up being high cost. And so I think that, that you would naturally expect at some level costs to increase because of the aging population and because of advances in medicine. If you kept medicine and need at where it is right now, yes, our costs from that will decrease, but it's not a static system. We're getting older and we're advancing medicine. But this will put us in a better position to deal with it than if we didn't do this now.
And one thing that we are moving toward, which Senator Aguilar referenced, is this idea of managed care, where you have a medical home and you get more attention to how to plan your medical life. And so we think that that will help contain costs as well, because there will be preventive work. So people won't end up going to the emergency room as much, even as they age. At least that's our goal.
And also, this is part of the package. There's also, Senator Aguilar mentioned long-term care. There are other things going on in the world of healthcare to look at how we can best deliver services to those people who need long-term services and supports. So, all of these things taken together, we hope will make a difference. But the other reality, as far as just healthcare is concerned, is if we do nothing, the costs are going to go up. And nobody's really
Much
talking.
worse, unfortunately.
Yeah, the status quo isn't going to fly.
We have a gentleman here who's with the Alliance for Retired Americans. I thought maybe you wanted to say something.
Well, in terms of my question, the other side of the equation is there's a lot of people without health insurance, and they don't see a doctor until they're critically ill and they go to the emergency room. And that costs a lot more than preventative care. That really pushes the cost of health care up. The fact that if people maintain their health, see a doctor regularly, which they can only do with insurance, then the ultimate cost of health care goes down because you don't have as much catastrophic care.
One of the people who I always talk about was a young woman I took care of with diabetes at Denver Health West. She was about 45, and she worked as a secretary and didn't have insurance. And every time she'd come in and say, well, I can afford 3 medicines today, which one should I get? Her blood pressure was high, her sugar was high. And what ended up happening was that her kidneys failed because of her diabetes, and she ended up on dialysis. And then she got Medicare, and I thought, what good is this? That we're paying for her now that she needs dialysis every year, and we wouldn't pay for her to take all her medicines when she was healthy. And that's some of what we're hoping to do with the Affordable Care Act, is pay for it early, help people stay healthy, keep working, keep buying their own medical care as long as we can. And then in looking at long-term care, trying to figure out how do we do more of that in the community. Because people want to live in their home, they don't want to live in nursing homes, and we need to work on how do we work it out so that people can stay in their homes as long as possible. It's cheapest and is what we want. So all of these things will be addressed. So costs will be significantly less than they would be if we hadn't done anything, but costs, I think, for other reasons will continue to rise in healthcare unrelated to this act. Caroline.
I have a couple questions. Are we looking at the hospital costs, like an emergency room visit? It shouldn't cost 5 times as much as a medical unit. That nurse isn't getting paid any more money than a nurse on the floor, but the ER is charging the insurance companies or the patient much more money for that ER visit. So is that something that's being evaluated?
This is one of my favorite topics. But let me tell you why. It's because we need hospitals and we need emergency rooms to be there 24 hours a day, 7 days a week. And so what ends up happening is that if all those urgent care visits go to Walgreens and Walmart, we don't have enough money to keep the hospital open 24 hours a day, 7 days a week. So the reason it costs so much more to go to the ER than Walmart is that we're helping to fund the hospital staying open 24 hours a day, 7 days a week. And in the best medical system in the world, there will still be some of us who get in car accidents, who have catastrophic disease like heart attack, and you need to be in an ER and treated within 4 hours. So we need to keep those things working and functional and available. The question is, how else could we do that other than the way we do it now, which is that when you go, it seems like, oh my God, they charged me $15,000 for a suture. If I'd gone to, my doctor down the street, it would have been $500. Well, your doctor isn't open 24 hours a day, 7 days a week with ICU specialists. And ambulances, whatever. So I think some of it is that we need to understand what we're really paying for and figure out if we really want to know what something costs, how do we get that paid for in a different way? Because at some level, we're all paying for that ER to be open 24 hours a day, 7 days a week, so that when we need it, it's there for us. But the way it comes out right now is part of an emergency room visit as opposed to part of, so you get this outrageous bill and it seems outrageous, and it is outrageous. But it's because you're helping to pay for that service 24/7. So it would be nice if we could find a way to do it where you saw what it really cost for what you did versus how are we all paying for that hospital just to be there for us when we need it.
Well, that's as a nurse. When I worked labor and delivery, the patient charge for a nurse was like $150. I was making $30.
Yeah.
And
that's
I
part of-
understand benefits and such like that.
Right, but it's overhead in the hospital and the CNAs
So
and.
that would be covered under the room charge, but that's just something to
Yeah,
look at.
yeah.
And then another situation, when I was in the hospital, I was waiting to get a repeat stress test. They had me laying down, we needed my pulse to come down by like 20, it needed to be below 60. I could have done a commercial for President Obama. Laying there, relaxing, and somebody from the business office came in with Medicare papers for me to sign. Said my bill was at $2,200. I tore the paper in half, told him to get the hell out of my room, that I was going to leave AMA. My pulse, you saw it go from 72 up to like 88, and it was supposed to be below 60. Luckily, at that point, the assistant head nurse came in. It was somebody I had helped train at University Hospital. We got the director of the business office in, and we got things rolling in a different direction. Called Kaiser, found out that had been in charge if it was outpatient. It's different if it was inpatient. But if that person wouldn't have walked in, if I wasn't a nurse, that was a different person. And left without the test they needed because this person walked in at that point. And my bill was $2,200 in the middle of my treatment.
So back in the early 1920s, late 1800s, most other developed nations chose to make healthcare part of the basic benefit they provided for their population, like fire and water and police protection. But doctors, we screwed ourselves and we said we don't want that. And the AMA fought it off in the United States and we ended up with the system we have now. And so for many people in other countries, you're not ever sort of approached and said this is what it's going to cost you and have to deal with that. And unfortunately, that's where our system is right now. And again, another day we'll talk about maybe an option to change that. But I agree that that to me just shows bad business and common sense and medical sense. But sorry. Yes, ma'am.
Yes, okay. I want to ask you one thing. Obama has taken $500 billion out of Medicare. So what kind of treatment is going to be left for people on Medicare? I mean, you're either going to see a nurse or you're not going to get treatment. They say there's a provision in that bill that if you're over 75, that they're not going to treat you if you have a serious illness. You will not receive it.
So I know that the over 75 thing is not true. I don't know about the $500 billion taking out of Medicare. I think what they're saying is they're estimating that in redoing things the way they're redoing it, they will save $500 billion from Medicare. Well, I tell you, in an interesting story, this is true. You know how as a senior, when you go to the doctor, you have to pay so much money every time you go? And at this HMO in California, Kaiser said, our seniors are going to the doctors too much. Let's make them pay more so they won't come. And so they did. They increased their co-payments from $20 to $50. And they were right. They cut the number of visits dramatically. You know what happened? The seniors ended up in the emergency room because they weren't going to the doctor and they got really sick. And so you know what that insurer said? Forget it, they get free visits to the doctor. So that's one of the ways in which Medicare is looking at how do we pay for things better? What are we doing that are increasing our own costs without even realizing it? So I think that you're going to see actually more access to care for seniors being a focus of our new healthcare system, because we know if we don't get people who are elderly with diseases the care that they need, bad things happen, and then it costs us more money.
But here's one thing. If you have somebody back there in Washington deciding what your medical care is gonna be. And you don't know, your doctor's switching, and they can overrule your doctor.
No, that's actually insurance.
The insurance companies.
Private insurance companies do that. Medicare actually, and Medicaid. I have a daughter who's pretty significantly disabled and she's on Medicaid. And from the patient's perspective, Medicaid and Medicare are the best insurance you have because pretty much they pay for everything. Once you get to private insurance, you get to a lot of things that aren't covered or that they can deny and your doctor can go through steps to try and get, but they can't. But the people have put a lot of pressure on our government so that Medicaid and Medicare are actually pretty robust. The people who suffer from that are the doctor's offices who don't get paid as much. And so that's another kind of pressure that's being put on is how can we make this payment more fair? You know, if we had more primary care providers and less specialists, our health population would be healthier and our costs would be less.
How if